Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone. We are going to resume our maternal medicine module inshallah, and today we have so many to cover actually, because recently there are lots of talk articles talking about cardiac disease in pregnancy, so we have to cover them all. Previously it was like one or two topics. Now we have acute MI in pregnancy, we have peripartum cardiomyopathy, we have arrhythmias, we have valvular disease in pregnancy. So it's a lot. And let me tell you, it's one of the most important topics in your exam, not to mention in your real life. Because only a good obstetrician can follow up a patient who have a cardiac problem. Not everyone. Okay, so you are going to be this brilliant doctor who know how to manage a patient with a cardiac problem during pregnancy. Let's start with talking about some physiology. And trust me, you are this effort you are doing now, it's not in vain. I'm going just to remind you that the physiology of pregnancy itself, it's very challenging. So when we are talking about someone who is having a problem in her pump, this is going to be a challenging pregnancy. Okay, so I have two people to take care of. The first one and my priority, of course, the mother. And secondly, I want to save this baby, and I want to make sure that um, moderate amount or average amount of blood is reaching this baby. He's not going to be SGR. This woman is not going to have a preterm. As much as we can, we are going to give the best care for her. So to do this, I'm going to remind you of what would happen during pregnancy. As you can see, those changes are the reason why the hemodynamic of pregnancy is not like everyone. So try to imagine if I'm having a patient who cannot cope with this change. Here is the problem. I have a woman who have something wrong with her muscle of the heart. For example, she is having a problem that affect the contractility of her heart, or she is pumping against a block or against high pressure. This woman is not going to have increased cardiac output like this, and this is going to affect the blood that's going to her organs and also to the baby. Not only the baby, her organs also, because she's having a second circulation, and she should cope with the second circulation, right? So now her heart has new demands. He have to uh, beat fast. He have to increase the cardiac output, the stroke volume, and the total peripheral resistance already is going to decrease to help this happen. So if this woman is having hypertension, this is going to be very, very, very tricky for her. If this patient is having aortic stenosis, this is going to be very hard for the heart to cope with, right? And so on. So this is one. We are in the first page. It's not appearing to you, this one? We are just here. I didn't say anything else. Okay, so in exam, talking about the exam, mostly they are not going to ask you about physiology. This can come for part one. Even those changes, the hemodynamic changes can come for part one. But you should bear in mind that if you don't really understand this, you are not going to understand what I'm saying when I talk about pericardial cardiomyopathy or valvular diseases. Okay, is everyone is having a problem with the screen? Can you see my screen? It's a table showing the hemodynamics. Okay, so here we are. Not only during pregnancy she's going to have a problem, but also during labor. This is a total another problem. Okay, can you imagine that I'm having intrapartumly increase again in the cardiac output, I'm having increase in the blood pressure. All of this is a strain on the heart. Can her heart keep up with it or not? Let's see. The ejection fraction, which is the amount of blood left in the ventricles after contraction, or the amount of blood ejected with each contraction. Normally, normally this should be 60%. In normal non-pregnant ladies, and also in normal pregnancy, 60%. So like a normal adult. If I'm having a decrease below 45, this woman is having heart failure, whatever the cause of heart failure. Okay, again, I'm having normal changes in ECG during pregnancy. My duty as a good obstetrician to know what's normal so that I can detect the abnormal. So if your lady came to you with atrial or ventricular ectopic beats, if it's not sustained, if they are not recurrent, if they are not causing symptoms, this is very normal. If you hold up her ECG and you find left shift in the axis, this is totally normal because of the effect of the uprising uterus upward, it's shifting the position of the heart, right? So the position of the heart is going to affect the electricity of the heart. This is why we have a left shift in QR axis or left shift in the axis. Also, it's very normal to see a small Q wave and inverted T wave, sometimes in left tree. And this is usually because of the tachycardia. And it's also normal to see ST segment depression with some T wave inversion in inferior and lateral leads only, not everywhere. Again, because of the dextroversion or the shift of the heart, because of the upward pushing of the diaphragm. Okay, all of this because of the change of the heart place. So I can expect this, yes, yes, yes. But if you see atrial arrhythmias, this is abnormal. If you see sustained supraventricular tachycardia, this is abnormal. If you see atrial fibrillation, this is abnormal. Okay, guys, so it's very important to remind yourself of what can I see normally in the ECG. So I'm not going to be worried or worry my patient, right? I'm not going to ask you to go for the Doppler parameters, but take care of one thing. The peak pulmonary artery pressure. If you ever have a report between your hands, the patient have done echo for whatever reason, or her GP was suspecting something or whatever, and while you are holding the report, you find the peak pulmonary arterial pressure is raised. This is totally abnormal, because even in pregnancy, with all those changed, the peak pulmonary artery pressure should not change. Even if the aortic root diameter is widened normally during pregnancy, this is normal. Again, the pulmonary artery pressure is not going to be affected. See, even if I'm having the annular size of the valves increased, again, it's not going to affect the arterial pressure, pulmonary arterial pressure. And I'm going to tell you in a minute that any woman with high pulmonary artery pressure, sometimes we are going to advocate not to get pregnant. Okay, we have a great fear from pulmonary hypertension. So here we are with the classification. We have two classification actually, but we work with the NIHA or New York Heart Association classification and the WHO. Both of them are very important, basic information. They have classified the symptoms, okay, and how the patient is dealing with those symptoms. Accordingly, they are going to make their mind about the state of the heart. So if you are having no limitation of physical activity and you don't feel anything with ordinary exertions, this is normal. Okay, this is totally normal. And if you are having a heart condition with no limitation of physical activity, you are class 1. If you are having slight limitation of physical activity, this is very subjective, because someone who can say, I don't mind going up the stairs or taking the stairs. The other one is saying, no, I feel very tired when I take the stairs, even for 10 stairs. So it's subjective. So they are saying, yes, when the ordinary activity causes symptoms, this is class 2. Like while washing the dishes, she's feeling dizzy and she's very breathless. This is ordinary activity, like moving around the house. Okay, this is ordinary activity. So if she's feeling tired with this activity, but still can do it, she still can do it. This is class 2. When there is marked limitation of physical activity, and I'm trying to give you examples because this is going to be very important, even if it come as a scenario or in part 3, inshallah, when you are going to counsel patients. When she's saying, I'm not able to do what I was doing before. So you are going to ask her, is it like ever? You can't ever do what you used to do before? She said, no, I can water the plants, I can get the newspaper, I can do some tidy the room, but I cannot do the dishes, I cannot do the laundry. So this is marked limitation because she is choosing less than ordinary activities to do. Okay, and she's still asymptomatic at risk. This is the pathognomonic line for class 3. Yeah, I have limitation for activity. I cannot do many things. This is very subjective. So I'm going to ask you about something. How do you feel while you are resting? Are you feeling breathlessness while you are resting, or your heart is racing while you are on the couch? If she said yes, this is class 4. If she said no, this is class 3. Okay, guys, we are going to use this to make our mind if this woman is going to get pregnant or not, if she can endure pregnancy or not. There is a scoring system, which is CAPRIDGE. CAPRIDGE is another classification that can predict cardiac complication in pregnancy. Okay, and the scoring system depends on many things. But anyway, it's good to know that this scoring system is not only for classification, it's for prediction. We are going to predict if there is going to be a cardiac complication during pregnancy or not. And they depend on if the woman is having NIHA class more than 2, or if she is cyanotic, if she's having left heart obstruction like aortic stenosis, left heart obstruction like pulmonary hypertension, I'm sorry. Systemic ventricular ejection less than 40, so this woman is having failure. If she's having previous pulmonary edema, arrhythmia, or so and so on. Okay. TIA's transient ischemic attack. She had previous uh, transient ischemic attack before. And we are going to make our mind. If her score is more than 1, it means that this woman have a chance to have complications more than 75%. So do you think that this woman can get pregnant? Are you going to advocate pregnancy for this woman? I'm asking you, by the way. What do you think if a woman got a score more than 1 in Cambridge scoring system, are you going to advocate her to get pregnant? Yes, of course I'm going to ask her, no, please don't get pregnant. Yeah, I'm going to tell her that this is very risky. The chance of cardiac complications is 75%. 75%. This is very high. And you know what? We have in the WHO classification, when a woman is having pulmonary edema or she's having left heart obstruction, okay, up to some level, she cannot get pregnant. Let's see. But I'm just telling the different scoring systems so you know about them. This is the WHO classification. Okay, so here we are. Here we are. In WHO, if she is in class 4, pregnancy is contraindicated. So what is class 4? See here. And I think this is exam question, by the way. I don't think they can ask about the gray line area, okay? But they can ask you about the mild cases or the severe cases who are contraindicated to get pregnant. Like, for example, when they had a question before about cardiac problem, and it was very, very new. They asked about ASD. Okay, so they asked about a condition that atrial fibrillation is a common complication with it, but the woman can bear pregnancy or can endure pregnancy. Okay, this is ASD. So it was like a charade. Anyway, in class 4, severe pulmonary hypertension, significant left ventricular dysfunction, severe stenosis. Yeah, Marfan. Yeah, definitely. Yeah, definitely. Marfan syndrome or uh, not down. Turner, Turner also can come in the exam as a cardiac complication. Ehlers-Danlos, because it's a connective tissue disorder. Yes. Here, if you are having a periportic cardiomyopathy and you still have residual impairment, Fontan type circulation, a total contraindication for pregnancy. Total contraindication. Aortic dilatation more than 5. She's contraindicated to get pregnant. Turner syndrome when she's having, or Marfan when they are having aortic dilatation more than 4 or 4.5, they are contraindicated. Those are important questions to know who is contraindicated to get pregnant. This is the team that is going to take care of the patient. Okay, the team is containing anesthesiologist and you, and of course a cardiologist. Okay, and if she's having any other problems, we are going to involve her GP also, special nurse, okay, special in cardiac pathologist, a specialist midwife, okay, not any midwife, but this patient is high-risk patient. Okay, now in the diagnostic testing, and we are talking in general now. Okay, so when I'm going to discuss with you each disease, it's going to be very easy. Usually in the scenario that come in the exam, or even a patient is coming to your clinic and she's having some symptoms, you should know what to order for this patient. So from the beginning, any patient, any patient with shortness of breath, with chest pain, okay, she's going to have ECG and chest X-ray. Those are basics, basics. Then according to the symptoms, I'm going to offer her extra investigation. So any patient, again, with cardiac symptoms, plus pulmonary symptoms. So I'm not really sure if she's having a pulmonary problem or this is a cardiac problem. So this is why I'm ordering two things, ECG and chest X-ray. Of course, the complete blood count, plus kidney and liver function, and all of this, this is also basic. But in the exam, you know, because it's theoretical exam, you have to choose one. They are going to ask you about the best next investigation, or what would be your first initial investigation. Right? Okay. If she's having symptoms for heart failure, which is she's having pedal edema, lower limb edema, with shortness of breath, chest pain, some hemoptysis maybe. Okay, so I'm having symptoms of pulmonary congestion that could be because of heart failure. I'm going to ask for echo. Okay, so the echo is going to tell me what is the ejection fraction is now. This is the most important thing. If the ejection fraction is less than 45, this patient is having heart failure. If the woman, her history for cardiac disease was totally negative, and she had those symptoms for the first time during pregnancy, this is peripartum cardiomyopathy. Okay, guys? So, no, not this. I'm sorry. Okay? So if the patient is having a total new symptoms, I cannot see any cameras. Look, you can from the settings, Dr. Jesse, from the settings, you can choose hide video panel. It's not going to appear for you. I do so. I do so, so it's not appearing for me. So, because I don't want you guys to appear in the recording. Okay. So you got what's basic? Those are the exam questions. No one is going to ask you about MRI angiogram or catheterization or Holter. Okay? We are not going to ask you this. But the basic is going to be asked about. Why? Because when she's not feeling well, usually she's going to come to you or her GP. If you or her GP, you should know what's going to be ordered. If they are abnormal, she's going to be referred for the cardiologist, and the cardiologist is going to ask or order further investigations. Okay, forget about the contraceptive methods now. We can talk about them. We need to know what are the red flags. What are the red flags for me? Those were very stressed about through not the latest embrace, the one that was released 2022, when cardiac diseases was the first cause of maternal death back then. You know that in the latest embrace, they are saying that both VTE and cardiac diseases are now equal. Okay, 1 or 2 years before, the cardiac disease was the first cause of death during pregnancy or postpartum, in early postpartum. So this is why there were a lot of campaigns and they were stressing over the cardiac diseases. And we had a lot of top articles talking about cardiac diseases. The red flags are shortness of breath at rest, severe orthopnea, more than 4 fellows. Those are signs of heart failure and pulmonary congestion. The resting heart rate is more than 120. The resting systolic blood pressure is more than 160. The resting respiratory rate is more than 30. Of course, if she's having those, she's going to have oxygen saturation more than 94. This is the cutoff, by the way. If you are having less than 95 for a normal person, this is hypoxia. For them, if it's 94 or less, and she is having personal history of chronic vascular disease or not, I don't care. Okay, I'm having hypoxia. This woman needs prompt evaluation plus or minus hospitalization. Because this woman, while being pregnant, she can die. Her heart is not going to cope with the changes of pregnancy. Okay, if the woman is having a personal history of cardiovascular disease and she's not having red flags, then she's going to have consultation, okay, in the primary care or the cardiologist, as we said before, and she's going to have her own MDT, okay, as we said. But this woman, no, she needs hospitalization, not only acute management. I love this table. I love it. Why? Because it's telling you when the symptoms are likely to be physiological and when they are likely to be cardiac. I think if you have nothing to have no time to go over everything, go through this. Go through this. Why? So this is how you are going to know if your patient is having physiological symptoms of pregnancy or this patient is having a cardiac problem, right? Even in the scenario in the exam. See here, first of all, the physical examination is abnormal. So dyspnea can be physiological symptom. Palpitation is a physiological symptom. Chest pain, it can be because of reflux. Fatigue, are you kidding me? All pregnant ladies are having fatigue. Back pain, even edema. Right? So when I can say that this edema is not because of pregnancy, when it's acute. And by the way, even acute edema can be not because of cardiac disease, it can be because of allergy, simply. But it's not going to be alone. It's going to be with shortness of breath. It's going to be edema plus fatigue plus chest pain, edema plus dyspnea, right? It's going to be acute. It's going to be asymmetric. Okay, and asymmetric does not mean unilateral, by the way. Asymmetric means that one leg is more edematous than the other. And by the way, you have just covered the VTE with Dr. Rabaa, right? If you are having a patient with peripheral edema and chest pain, what you should exclude? She's pregnant and she comes with edema and chest pain. What you need to exclude? Actually, I need one other symptoms, but I didn't say it out loud. Yes, DVT that can lead to pulmonary embolism. Yes. So the other symptom that's going to make you very suspicious for DVT is pain, redness, hotness, and usually it's unilateral. Usually, not 100% of patients are going to be unilateral. Sometimes it's bilateral in severe cases, but usually it's unilateral. Unilateral edema with pain, hotness, redness, and chest manifestation. I should exclude pulmonary embolism. This is my job. If it came out to be anything else, I don't care. But I'm a lifesaver. I want to exclude that this patient is not having pulmonary embolism. And trust me, I have met patients who had pulmonary embolism because of wrong diagnosis or misdiagnosis. Okay, and usually she's going to collapse and came to the hospital when she is collapsed and from the ER to the ICU. While when she came before, while she was just having symptoms, okay, and no one cared. So here we are. Usually in the scenarios in the exam, they are going to tell you that the patient is having dyspnea, okay, palpitation, she is having chest pain, at rest, and some back pain. Okay, back pain can happen, by the way, if you are having gastric problem or cardiac problem as a referred pain. With edema, some of them are having cough or even hemoptysis, as you can see here. Okay, some of them are going to have orthopnea. Yeah, why not? She's going to tell you that I cannot sleep unless I have put like 3 or 4 pillows behind my back. By examination, you are going to find if the lungs are clear or not. You can make your mind if this is pulmonary condition or cardiac condition. Accordingly, you are going to order your basic studies. Those are the basic studies. ECG, chest X-ray, and then I can order the echo, I can order the PNP, I can order the lactate dehydrogenase, whatever I want, I can order them. Okay? Palpitations also can be because of arrhythmia, so ECG is going to get me this. ECG is going to tell me if this is arrhythmia or not. If the suspicion is very high, we can get her a Holter. You know the Holter? 24-hour Holter? Okay. And yeah, it's like an ECG, but it's continuous through whole the day. Yeah, 24-hour monitoring. And it can tell us if she is really having supraventricular tachycardia or ectopic beats. We're going to see if they are sustained or not. Because maybe she had acute attack, but when she came to us, she was okay. So the ECG is normal. And she is swearing that she's having symptoms or even collapsed. So yes, we can offer the Holter at this time. Okay, again, the algorithms here are great, but I want now to discuss uh, some isolated disease with you. Here we're having some numbers, and I have heard that your colleagues have some numbers in their exam. They are saying the numbers are a lot in today's exam. So what we can say, we need to know the overall risk of having a congenital heart disease is in the baby is 2 to 5. It's going to increase if the mother is having uh, a chronic heart disease. If the father is having only the risk is going to be 2. If one of his siblings are having a chronic heart disease, again, it will be like the overall risk 2 to 5. If 2 of his siblings are having the disease 10 to 15, that means that it runs in the family. If the mother or the father are having autosomal dominant condition, like Marfan, okay, for example, this is the most famous one. We're talking about 50% risk. All of them can come in the exam. Okay, this is very important, guys. Now, let's see another, or let's say a specific cardiac disorder. Okay, you can see this is a collection for all the diseases here. So it's like a revision for you. If you want to revise all the cardiac diseases, it can be like a revision for you here. But we are going now to, and I have put some strategy questions also. Okay, let's talk about the myocardial infarction in pregnancy. There's 2 articles from 2013, but guess what? All of them are there. All of them are there in the portal. Okay, this, guys, is an old article, but it's gold. Because up till now, we don't have a guideline for acute MI in pregnancy, and it still appear in the exam. Up to this moment. Why? They love to ask you about the antenatal care or intrapartum care. That's it. So if a woman is having acute MI, how you are going to diagnose her? Like any MI on this planet. MI is having a pathognomonic symptoms, which is chest pain, acute chest pain, or epigastric pain with dizziness, with dyspnea. Okay, that's it. Usually, it's going to be very severe pain that the patient is holding his chest. And sometimes, and I have seen it by my own eyes, I have met patients who have acute MI while it was only mild pain but sustained, and they are feeling dizzy. So their colleagues at work were telling them, no, you should not go to see someone. You should go to the hospital. Don't, please take it seriously. And I remember this case, and he was coming very, very good, in a good condition. He's just saying the pain is not really severe. I can endure it, but it was from the early morning until now. And what else are you feeling? I'm feeling really dizzy. I cannot concentrate. And guess what? The ECG came out with huge ST elevation. A huge ST elevation. The patient is having acute MI. So symptoms can be sometimes vague, yes. In pregnancy, it's not going to be vague because this woman is having hypercirculation. So acute MI is going to cause some symptoms. And like any other human being, she's going to have ST elevation, ST depression, symmetrical T wave inversion. Those can be physiological, so they are misleading. But ST elevation with newly developed Q wave, this is pathognomonic for acute MI, and this is exam question. I'm going to depend on ST elevation or a newly developed Q wave. What I'm going to order. See, I'm repeating myself over and over because I know that you are going to answer question afterwards. So I want you to come out from this session directly to the question and you can answer them, inshallah. First, when I'm having those symptoms, ECG and chest X-ray. Okay? Forget about the troponin. Forget about the echo. Forget about the angiogram now. Those are complementary. There are secondary investigations, not primary. Okay, guys? Yeah, we order them. But those are not the first line. Okay, what I'm going to do, if this woman is having acute MI, like any other human being on earth, MDT, of course, if I have detected where the occlusion, I'm going to do a reperfusion therapy. Usually when we have ST elevation in the ECG and you have called the cardiologist and called the consultant and everyone, okay, they are going to order the coronary angiogram. Coronary angiogram is diagnostic and therapeutic at the same time. They are going to insert the catheter and the catheter have a camera. They are going to see where the occlusion is and simply dislodge the ampullae and put a stent. This is what we call percutaneous coronary intervention. This is the treatment of choice if the woman is having ST elevation MI. This is SBA. Okay? How? By coronary angiogram. Percutaneous means they are going to insert the catheter from the femoral or sometimes the radial artery until they reach the coronary arteries. You are going to see where the occlusion is, okay, by inserting the dye, of course, and dislodge the ampullae and put a stent. In pregnancy? Yes, in pregnancy. Okay. What is the thrombolytic agent of choice? If I'm going to give her a thrombolytic agent, this would be intravenous TPA. What would be the first line management if this woman is having non-ST elevation MI? Like ST depression or a T wave inversion or a newly developed Q wave. We are not going to do coronary intervention. We are going to give her antiplatelet drug. Okay, easy until now. Another exam question is, what are the medications that can be used in MI? Which one can be used in pregnancy and which one is contraindicated in pregnancy? And honestly, if such a question came in the exam, they have every right to bring such question in the exam. As an obstetrician, you should know what can I give this patient and what not. Low dose aspirin is safe. Low molecular weight heparin is safe. Labetalol is safe. What about nitrates? Nitrates are vasodilators and I need them. Right? So can I give her nitrates? If she's having severe hypertension, if she's having severe pulmonary edema, but you should bear in mind that they can cause some fetal distress. What about nifedipine? Ifadibin is really good, right? And it's antihypertensive, and it can cause it's a calcium channel blocker. It's really good, but guess what? It should be avoided in cases of acute myocardial infarction. Even they have found that it increased the mortality. Has something to do with, like when you are having someone with very high blood pressure and you give him something that acutely drop the blood pressure. It's something like this. This is why nifadipine should be avoided for acute infarction. Keep it in your mind. Clopidogrel, antiplatelet, and it's really good, right? Oral anticoagulant. Yeah, it can be used, but for short duration because we still don't know its safety. And you all know that most of the drugs does not have antidotes or something to reverse their effects. So if this woman went into labor anytime or had hemorrhage because of clopidogrel, I don't know how to stop it. Right? Why? Because it takes 5 to 7 days to reverse its action on the platelets. See, now you are going to be very thankful for the pharmacology of part 1. Do you remember the drugs? Direct oral anticoagulants? Do you remember them? Alhamdulillah. If you remember them, then you're great. Okay, what about ACE inhibitors and angiotensin receptor blockers? Totally contraindicated in pregnancy anyway. Okay, so I'm not going to give it to her, even if she's hypertensive. So if I'm having a woman with acute MI and she is hypertensive, what can I give to her because of renal toxicity accident? I can give her labetalol. Yes. Can I give her aspirin? Yes. Low molecular weight? Heparin? Yes. Can I give her statins? There are a hell of debate around statins. There is a huge debate around statins because they are saying, guys, it's not that risky. Please, if the woman is having high levels of lipids and cholesterol, she needs statins. Otherwise, yes, of course, it should be avoided because decreased synthesis of cholesterol can affect the fetal neurodevelopment. But if the woman is having hyperlipidemia, guess what? They are going to give her statins. Okay? So it's not totally contraindicated. It should be avoided if you don't need it. Now, the timing and mode of delivery, this is one of the most common recalls. When you are going to deliver a woman that just had acute myocardial infarction, if this woman is having the acute myocardial infarction, like in the second trimester or so, and she does not have any kind of delivery. So, okay, this is good. But in general, you should delay the delivery by 2 to 3 weeks after the attack. So if she come to you in the third trimester or near term and she just had acute myocardial infarction, this is where the challenge is. It's going to be very challenging. We need to delay the labor by 2 to 3 weeks. Are we going to deliver her by vaginal route or cesarean section or what? Actually, she can have a vaginal delivery. she's not going to be offered cesarean section unless for obstetric reason. Or on the contrary, vaginal delivery is much better than the CS. However, if you choose to deliver her vaginally and the patient choose to have a vaginal delivery, you should bear in mind to use epidural analgesia. It's going to make the second stage much less painful, and this is going to be less stressful for her heart. Left lateral position most of the time, supplementary oxygen, continuous TTG, shorten the second stage with instrumental delivery if you can. If you are going to use oxytocin, you can, but use the slow intravenous infusion of oxytocin, not the usual dose of oxytocin that we usually use for any other patient. This one is called slow intravenous infusion, 2 units per minute. Ergometrin is contraindicated, and of course, this woman is going to deliver in obstetric-led care unit. I don't know what's doing this. Right? ICU if she needs it. She needs, and usually they are going to be monitored in the ICU. Okay, but not full admission. Okay, can we use something during labor to protect her from another attack of myocardial ischemia? Usually this is not going to be done by us. This is going to be given by the anesthesiologist, but anyway, yeah, apart from the pain management, you can give her nitroglycerin, beta blockers, calcium antagonists or calcium channel blockers, okay? But take care that nitroglycerin and calcium channel blockers have tocolysis effect, so they can prolong the labor. Okay, so there is this famous EMQ about a woman with acute and iron pregnancy. Okay, and how you are going to counsel her about delivery. And you are having like 16 choices between vaginal delivery only, vaginal delivery with epidural, vaginal delivery with epidural and instrumental delivery, spontaneous labor, induced labor, wait 2 to 3 weeks. This is one of the choices. Elective cesarean section by 37 weeks, elective cesarean section by 38 weeks, and so on. Guess what? It's much easier than this. We are just going to postpone the delivery 2 to 3 weeks from now, whatever what the scenario is. And she can have a spontaneous labor. She can have induced labor for obstetric reason. She can have a vaginal delivery, or she can have elective cesarean section. I don't know. I have no idea. You haven't told me about her obstetric history. And who knows? After 2 to 3 weeks, what could happen? So how I should tell her, you should have a vaginal delivery with epidural and instrumental delivery. No, this is not the right answer. You got what I mean? If I'm going to choose something that I'm going to tell her now, I'm just going to tell her that what we are going to do now is to postpone the delivery 2 to 3 weeks. After 2 to 3 weeks, we are going to make our mind about the mood, what you need to do. Are you okay with having a continuous CTG or not? Are you okay with having an instrumental delivery or not? She may refuse. Okay, she even can refuse the epidural. I hope you got my point. Okay, for the postpartum care, all of cardiac diseases are having the same postpartum care. Again, it should be under MDT, the GP should be updated with everything happened. The cardiologist is going to be there. The contraception is going to be chosen according to her cardiac condition, which is we are going to avoid estrogen containing contraception. The best contraception for cardiac diseases are the intrauterine devices, whether it was copper or Mirena. Come next to them, progesterone only contraceptions, whether it was the POP or the implant or the injections. And I think that you know which is the best one regarding the failure rate. You know which one have the lowest failure rate of all of them? Yeah, Dr. Rafa has answered. Yes, yes, the dimple. Okay, so this is why it's the favorite for many patients, by the way. Okay, I honestly favor the implants if she is not going to comply with coming to have her injection. Okay, those are the risk factors for the MI. Keep it in your mind. And of course, if she's having eclampsia, hyperlipidemia, thrombophilia, anything that could lead to the formation of a thrombi, anything, obesity, smoking, okay, diabetes, all of them are risk factors. The ECGs, here again, they are telling you what could be normal, what could be abnormal. So we are having ST elevation, ST depression, symmetrical T wave inversion. Remember, please, T wave inversion is normal when it is in inferior and lateral leads only. Okay, ST segment depression again in lateral leads. The Q wave in AVF only. And as a woman with a previous heart condition, mostly they are going to be a chronic disease patient. So you can compare her ECG with the previous ECGs to know if she's having a newly developed Q waves. Okay, guys, again, those are the medical management, which is contraindicated, which is having limited use, which can be safely used. Take care of the nifedipine. Okay, it should not be used if you are having acute MI, as we said, not after the episode directly. Okay, and it should be avoided. No, not after the attack. Are we good until now? Next would be the peripartum cardiomyopathy, the reason why everything was upside down in the past 2 years, because as you can see, it was the most common cause of maternal deaths. And this condition is, what can I say? It's coming from nowhere. The woman was okay. She's not having any history of cardiac disorders. And out of the blue, she came with cardiac manifestation. And if she is not correctly diagnosed, she would die. And this what already happened. This what already happened. And but this was from 2018 to 2020. Okay, myocardial diseases and cardiomyopathy was 25% of all cardiac disorders. So this is why they had this article to talk about it. The definition is the key, how you are going to diagnose this. It's idiopathic. This is one. The woman is having left ventricular systolic dysfunction out of nowhere at the end of pregnancy or up to 6 months following delivery, after exclusion of everything else. We are going to be left with acute heart failure that we don't know how it happened, and the woman is pregnant. So this is why it's called peripartum cardiomyopathy. Ejection fraction is nearly always reduced below 45%. Those are the criteria, and the criteria are the key for correct diagnosis. Okay, what I'm going to do with this patient. As you can see, this is from the Embrace record, and they are focusing on the red flags. Okay, they even have a campaign called Saving Lives, Improve Mother Care. So if a woman is having restlessness at rest, unexplained cough, or frothy pink sputum, pulmonary congestion, paroxysmal nocturnal dyspnea, pulmonary congestion, palpitation out of nowhere at rest, something is wrong. Something is wrong. So at this point, and I brought you a real case. This is a real case, by the way. Okay, so you can go through the history and see how they dealt with her. As you can see, her oxygen saturation was 95 while receiving a 2-liter laser cannula. So this woman was hypoxic, and she was obese. She had gestational hypertension, dependent peripheral edema, symptoms of upper respiratory infection. So now, if this woman is having a respiratory infection, a pulmonary problem, or a cardiac problem, what's going on? They had investigation. The lung was clear. The heart rate was regular. So I have excluded lung infection. I have excluded arrhythmias, right? But the S3, she has S3 gallop. If you can remember, or anyway, S3 gallop is something that you are going to hear when the heart is beating heavily. Boom at S3. This what would happen in heart failure. No cough tenderness. See, this is very important. Now she's not having edema. Okay, the edema was dependent. So we excluded DVT. Right? Even by urine analysis, it was negative for protein. So she's not having preeclampsia. In this facility, they ordered the D-dimer and PLT. In our exam, this is not the first line. In our exam, we are going to do ECG, chest X-ray, and both of them showed us normal rhythm, cardiomegaly, increased vascular congestion bilaterally. And by auscultation, the chest was normal. So this is what? This is a cardiac or pulmonary problem. Up till now, this is what? A pulmonary problem? She's having a cardiomegaly. I'm sorry, chest problem, not to be specific. This is not a chest problem, right? This is a cardiac problem that causes pulmonary hypertension or pulmonary congestion. This is what heart failure is. Okay, then ordered a CT, okay, for chest, and it came out showing pleural effusion and cardiomegaly. There is no impulse. So this woman was diagnosed as peripartum cardiomyopathy. She received that treatment. Okay, she had a transthoracic echo, and it came out to show the ejection fraction is 35 to 40. She was given beta blockers, okay, as you can see, and she was given also lisinopril. So everything was good. She was well controlled, and at follow-up, she had a stable cardiomyopathy, well-controlled hypertension, and the ejection fraction improved. This woman, this very woman, if she's having residual effect in her heart, the ejection fraction came to normal, but she still have cardiomyopathy, or she's having any other cardiac problem seen in echo, is she going to be um, approved for getting pregnant, or pregnancy is, I want to use the correct term. Is pregnancy is okay for her, or she should avoid pregnancy? If she's having any residual cardiac manifestations or residual problem, she should avoid pregnancy. Yes, she should avoid pregnancy. First of all, she's very risky to have another attack of heart failure. Okay, and by the way, we don't know why this happened. We have a theory for this, but it's just a theory. And the theory is there is a combination between blood vessels atheromas and inflammation in the blood vessels and the coronary artery, plus the high level of prolactin, and prolactin is doing something with the immunomodulators and the inflammatory modulators, and all of them together ended with affecting the contractility of the heart and the blood vascularization of the heart. This is a theory, but we still don't know why this happened during pregnancy. So this woman should avoid pregnancy if she's having any residual effect from this peripartum cardiomyopathy episode. How we are going to manage her? Like anyone with heart failure, but we are going to avoid the teratogenic drugs, ACE inhibitors and ARB inhibitors. We can consider promocraptin because the theory is saying that prolactin has something to do with this. So we can consider promocraptin as one of the line of treatments. Okay, so because dopamine antagonists, right? We can give her low molecular weight heparin, especially if she's going to take promocraptin. If this woman came to us in case of cardiogenic shock, we can consider something called levosimendan instead of adrenaline as first line inotropic drug. You know, you all know that in collapse, we use inotropes, right? So the inotrope that we usually use is adrenaline. In this case, if a woman is coming to you in a collapsed state and you have diagnosed her as periportum cardiomyopathy, and now she's having cardiogenic shock. You can consider levosimendan. Why I'm saying this? Because you guys choose levosimendan in cases of collapse scenario instead of adrenaline. For what reason? I don't know. I don't know. Adrenaline is the best. This is the first one. Unless in the scenario he is telling you that this patient is peripartum cardiomyopathy and now she's having a cardiogenic shock. What would you give her as inotropic drug? Yeah, I'm going to choose the levosimendan. The promocretin is going to decrease the level of prolactin. Do you remember the capergolene and promocretin? Because they are dopamine antagonists. Or agonists, I'm sorry. I always confuse them. So someone remind me. Am I right? They are antagonists, right? Yeah, we use them. Yes, even in yeah. Okay, I doubted myself. We use them for high prolactin levels anyway. So because there is a theory for periportum cardiomyopathy, and prolactin is one of the reasons why they are saying that, yeah, prolactin, we don't know. You want to know? You can read about it. They are saying that prolactin is promoting some of immunomodulators. At the end, it's going to cause vascular inflammation, and this could lead to the cardiac problem. Look, I don't remember agonist or antagonist. Okay, it's not in my mind now, but it's going to decrease the prolactin level. I think agonist. Dopamine receptors decrease prolactin release. Yes. So yeah, capergolene and promocretin are dopamine agonists. If you are sure that this woman is having periportum cardiomyopathy and she came in cardiogenic shock, levosimendan is better than adrenaline. You can consider levosimendan. Why? You can ask them. They didn't say why, and I honestly don't know why. It's what mentioned in the guideline with no reason. But of course, if we go deep and see why they favor levosimendan over adrenaline, we can get out why. We can go through the studies that was the reason why they had this conclusion. Maybe it gave them a better contractility, or it saved many patients other than those who were given adrenaline. Maybe, I don't know. Yeah, maybe it's having a direct effect. Adrenaline is having a direct effect on contractility of the heart. Okay, anyway, as you can see, when we are treating periportum cardiomyopathy, it's always pharmacological treatment. Okay, keep in mind, but this can be EMQ, if you are going to give her low molecular weight heparin, you should continue this 6 to 8 months postpartum. Okay, so this could be EMQ. This is different from any other case, especially if she was one of the cases who were offered bromocriptine as a line of treatment. So this woman is going to need anticoagulation. And please don't ask me why. Of course, they are going to be at higher risk for VTE. Okay, the exact management, the exact mechanism, I don't know. Okay, at labor. Can you see? Same, same to same. All of them are going to need left lateral tilt. All of them are going to be offered epidural. All of them are going to be offered limitation of active phase of second stage by instrumental delivery. Is this a must? No, it's not a must. Left lateral tilt is okay, we can do this, but you cannot force the woman for having epidural. You cannot force the woman for having instrumental delivery. And of course, some of them, they are crazy, but what can we do? Some of them refuse medication. Some of them don't like medication, so they are going to say, no, I don't like to have oxytocin. I have heard that oxytocin can cause me more pain. Counseling. This is not any kind of oxytocin. It's a slow infusion of oxytocin. And this should be done by 28 weeks, by the way. This counseling thing and detailed management of labor, which type of labor do you want to have, what kind of medications are you okay with, which medication is really good for you and helpful for your case. Like, for example, slow infusion of oxytocin, as we said. We're going to give her, it was 2 units each minute, okay? This is not like IM infusion or IV infusion that we usually use during the active third stage. Okay, this is different. You should know if misoprostol or carboprost are there at your facilities and you don't have the slow infusion oxytocin. Okay, I can use them to reduce the risk of hemorrhage. Long-acting oxytocin or ergometrin should be avoided. You should keep in your mind, if this woman is having symptoms preterm, okay, think about the corticosteroids. Giving her corticosteroids to promote fetal lung maturation. Okay, so this is easily what peripartum cardiomyopathy is. If you know how to deal with any cardiac case, you are going to deal with any cardiac case. A little bit difference is going to be between this woman and a valvular disease woman. How? I'm going to show you. Because in valvular disease, the woman could have a problem like, let's say, aortic stenosis. Okay, so this woman is having a problem with her cardiac output. You agree? Right? So this woman is going to need extra care. They call it the balance between input and output. You should always have this sensitivity to have this balance. So this woman cannot have any kind of fluid resuscitation. It should be monitored and calculated. You should always monitor her blood pressure. You should always monitor for any signs of pulmonary congestion, right? So this is why valvular diseases are a little bit different. So let's see. Again, if the case is mild, whether it was mitral stenosis or aortic stenosis, they are going to be okay. We can bear pregnancy. We can have a good outcome of pregnancy. But if it was severe, she should be counseled against pregnancy. Of course, this in case she came to you in the preconception clinic. But if she came she came to you pregnant already, what happened. So if the woman was not treated before pregnancy, or she would have was having mild or moderate situation before pregnancy, and now after pregnancy, you are going to offer her echo, of course, and we are going to see the valve state. So if we have a severe case now in front of us, we can offer her treatment. Yes, we can offer her treatment. During pregnancy? Yes, during pregnancy. Usually carried in the second trimester, okay? Not at the first, and of course, not at the third. And at any point, if pregnancy is causing her progressing of symptoms or a deterioration in her heart condition, of course, we can offer her termination at any time. So what would be the treatment for a severe MS or aortic stenosis? Percutaneous balloon valvotomy or valve replacement. So percutaneous balloon valvotomy, of course, it's not going to be as severe or invasive like valve replacement, but the outcome of valve replacement is better. Recurrence uh, of the valve problem, not at the short term, but in the long term, is common, of course, with the percutaneous balloon valvotomy. The most common problem with those patients are prematurity, early delivery, preterm delivery, fetal growth retardation. As I said before, her cardiac output is not optimum for having another circulation. She's having two circulations inside her body, and she can hardly have good circulation for herself. So yes, we can expect placental aging very quickly, so prematurity, preterm labor, and of course FGR. Not to mention that if she is having a valvular condition, like inherited one, like for example, Ehlers-Danlos, Marfan, if she is Turner, okay? So we are talking about transmission of congenital cardiac defects. This would be around 10%. And in this case, we are going to offer her fetal echocardiography. We usually do the fetal echocardiography by the time of congenital anomaly scan, 18 to 20 weeks. What about regurg valve lesion? Usually they are they don't have very severe complication. Pregnancy are well tolerated. Okay, so most of regurg conditions are going to be well tolerated and there no much complication. On the contrary, sometimes in regurg conditions, when with the hemodynamic changes in pregnancy, they are going to have better uh, blood flow to her brain, at least. she's, she's not going to be fatigued like outside of pregnancy. At least in the golden period of pregnancy, it's like uh, the 5th month, the 6th month, the 7 months, not at first and not at the end. We're going to monitor them by regular echocardiograms to assess the valve function, of course. And of course, they are going to have MDT. And again, I'm feeling like repeating myself here. Beta blockers, anticoagulation. For everyone? No, not for everyone. We said if the woman is having hypertension, if she's having hemodynamic stress, she can have a beta blocker. If she's having arrhythmia, she can have a beta blocker. Who needs low molecular weight heparin? Usually moderate to severe stenosis. Women with history of embolism or left atrial thrombus, like people who are having mitral ASD, sorry, ASD. They are very prone to have atrial thrombi. So those usually have a history of atrial thrombi. Those need low molecular weight heparin. Okay, if they are having left atrial enlargement or congestive heart failure, they need it. Can I give them diuretics if they need it? Yes. And usually it's not going to be our call. Cardiologist opinion also. See, here exam question. If you are going to do surgical management or interventional management, this should be done pre-pregnancy, if we can. Okay? Especially if she was NYHA, I call it NIHA class 3 or 4, or she's having pulmonary arterial pressure more than 50. Please remember the number. In this case, and she's coming to you in the preconception clinic, you should not advocate pregnancy and you should advocate interventional management. If she is depending on medical management only and you have done the echo to assess her case, or they told you that she is NIHA class 3 or 4 and she wants to get pregnant, okay, she embarks on pregnancy, okay, I'm going to offer her intervention. Maybe after the balloon valvoplasty or even valve replacement, she's going to be better. Her classification get down to class 2. Now you can get pregnant. Again, vaginal delivery is possible unless she's having obstetric reasons. But those patients usually are going to be covered with low molecular weight heparin or warfarin, especially those who are having valve replacement and they are having metallic valve replacement, which is the best, by the way. Metallic valve replacement is endurable and as a long-term management, they are the best, but they are more prone for formation of thrombi. So this is why we need to give them warfarin. So you need to know when to stop warfarin and when to give her back warfarin. This type of management or bridging is crucial. It's crucial, guys. A woman who is on warfarin and she's now pregnant, if she is controlled on warfarin and her cardiologist is telling you, I'm sorry, her case is not a good case for low molecular weight heparin, I want her to continue on warfarin. Are you going to tell her, no, no, I want to stop warfarin? She is in the first trimester and warfarin is doing imperiopathy and no, 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 it's contraindicated. We are not going to do this. Warfarin can be given in the first trimester. Okay, but we are going to keep our eyes on her. By ultrasound, we can detect if there is any kind of warfarin imperiopathy and we can deal accordingly. Okay, but she is our priority, the mother. So yeah, she can continue on warfarin. So when to stop warfarin? When we are going to stop warfarin in this case? Can you remember? Can you remember when we should stop warfarin before labor? 5 days before surgical interventions or operations, but this is out of pregnancy. In pregnancy, when should you stop warfarin and shift it to low molecular weight heparin? I can tell. If you want to stop it in the first trimester, okay, yeah, you can stop it in the first trimester, shift to low molecular weight heparin, okay, and again return to it after delivery. But this is not my question. My question is, if a woman was on warfarin, okay, for the whole duration of pregnancy, when are we going to stop the warfarin? Two weeks before delivery. 2 weeks before delivery. Okay, and we are going to shift for low molecular weight heparin. Okay, when are we going to stop the low molecular weight heparin? Of course, you are not going to continue her dose until during labor. We should stop it. She's having therapeutic anticoagulation. So there is no way now we are talking about prophylaxis. Yes, we are talking about therapeutic anticoagulation, not prophylaxis. So we should stop it 24 hours before any kind of neuroaxial anesthesia. Whether she's going to have epidural or spinal. Okay, so you should stop low molecular weight heparin 24 hours before labor. If this woman is having a risk of stopping anticoagulation, her cardiologist is saying, please put her on heparin, okay, as much as you can. So, yeah, I can stop the low molecular weight heparin 24 hours before labor and make her on unfractionated heparin. Unfractionated heparin can be stopped 4 hours before active labor. This is IV. So I can stop it once she is in active stage. At least first stage, active first stage. Which means I can stop it by being cervical dilatation by 4 centimeters or more. Or when she have regular contractions. So now I have covered her with anticoagulation, and at the same time, I'm avoiding any kind of excessive bleeding during labor as much as I can. Got it? So now, again, the numbers. If a woman is on warfarin all along the pregnancy, when should I stop it? 2 weeks before labor, and sometimes they stop it by term just in case, by 36 weeks. Okay, so by 36 weeks, because we are waiting for delivery at any time, or if she is stable, we can, or if she's going to have elective labor, we can stop it 2 weeks before elective labor. Okay, we are going to shift for low molecular weight heparin, right? So when should I stop the low molecular weight heparin? 24 hours from the day I'm going to insert the epidural or spinal anesthesia, the day of delivery. If the woman is hospitalized and she is on unfractionated heparin, this can be stopped 4 hours before labor. Okay, guys? Same indications for cesarean section, same precautions like any cardiac disease, the left lateral tilt, decreasing the second stage by instrumental delivery if you can. Okay, if you are going to give her oxytocin, again, the slow infusion. Don't give her ergometrin. Don't give her carboprost if she is asthmatic. Misoprostol is okay. Misoprostol, by the way, is known with the shivering side effect. Okay, so keep this in mind. And some kind of anesthesia, spinal anesthesia, also is known for having shivering as a side effect. Okay, this is the infusion rate of oxytocin, which is 2 to 8 drops per minute. This is the anesthesia aim. We want to avoid hypotension. We want to maintain the heart rate adequate. We are going to have strict fluid management if this woman is having pulmonary edema. Adequate cessation of anticoagulants. This is why I'm telling you this is crucial. Or the woman is going to have spinal hematoma or epidural hematoma. What about the postpartum care? Those women also are very risky. They are going to have rapid hemodynamic shifts, and their heart rate with their diseased valve is not going to stand this. So we are going to adjust the low molecular weight heparin and fluid management postpartumly very strictly. This is exam question, guys. The infusion rate of unfractionated heparin. Usually in the short time postpartumly, because you cannot resume the low molecular weight heparin unless 4 hours have passed from the removal of epidural. Do you remember this question? You should calculate 4 hours from the removal of spinal or epidural. Okay, and then you can resume the low molecular weight heparin. So in those 4 hours, you are going to leave the patient without anticoagulation? No, of course not. So usually they are going to be given unfractionated heparin. How you are going to monitor the unfractionated heparin? By APTT. Again, those patients are very risky for having thrombi. Right? We agree on this. They are having valvular problem. And valvular problem is having turbulence, whether it was stenosis or regurg, there is turbulence in the ventricles and turbulence in the atriums according to what type of valve is affected, okay? And whether it's stenosis or regurg, in any way, they are very prone to form thrombi. So this is the timeline of delivery. I have stopped the low molecular weight heparin before delivery. And now I have put her on unfractionated heparin. The unfractionated heparin is going to be stopped 4 hours before active labor. She had labor, okay? And now I want to put her back on anticoagulant. I cannot give her low molecular weight heparin because she's going to be still at risk for spinal or epidural hematoma. Okay? So we don't give low molecular weight heparin. So if I want to cover her, what should I give her? Again, unfractionated heparin. Why unfractionated heparin? Because it has short half-life, okay? Very easy to monitor. Give protection for short time. In simple words. And I can adjust the dose, sorry. I read antidote and say dose. You can adjust the dose. Increase, decrease, and so on. Yeah, sure. So here, if you are going to
Ma'am,
give, yeah,
ma'am, I want to ask, what is the difference between mechanism of action of low weight heparin and unfractionated heparin? One thing I understood, unfractionated heparin is short acting.
yeah,
So,
both of them are heparin. There is no difference in mechanism of action, but the half-life is different. The dose is different. Okay, the way you can give the unfractionated heparin is IV. Low molecular weight heparin is usually given subcutaneously and in very strict doses IV. Okay, and unfractionated heparin is, you can say, have shorter half-life than the low molecular weight heparin. This is why we can use it in those strict conditions, not for everyone. And I'm going to tell you, usually those patients are having anesthesiologist with you, the cardiologist is with you. But for exam question, they are going to tell you how you are going to adjust the infusion rate of unfractionated heparin according to APTT. Okay, welcome there. So if it came out 1.5 to 2.5, you are going to continue the infusion rate you have already given. And you are going to do the next APTT in the next morning after 24 hours. If the APTT came out to be 2.5 to 3, you need to decrease the dose by 2 units per kg. What if it was less than 1.5? increase the dose. Less than 1.2, increase the dose more and more. See, we are monitoring according to her case. The ratio, when it's very low like this patient is very prone to form a thrombi. When it's high like this means she is now prone to bleed. So I'm going to decrease my dose. I cannot do this with low molecular weight heparin. I cannot do this with low molecular weight heparin. And if you remember, low molecular weight heparin as a subcutaneous injections, they are pre-calculated doses. We have injection in 40, okay? We have injection in 80. This is the highest one. And you are going to divide it according to her weight. So most of women are given 1 injection per day, 2 injections per day, right? And you cannot stop them. There is no antidote. There is no antidote for low molecular weight heparin, and there is no reliable test to monitor it. Unfractionated heparin can be monitored. It has something to do with the pharmacology, so don't bother your mind. Okay? So this is exam question. I'm saying again and again. Now we can talk about the contraceptions. As we said, you are going to avoid estrogen-containing contraception. You are going to offer intrauterine devices. Then progesterone. So progesterone is not our first choice? No, because some studies said that it can affect the INR levels of those women, especially those who are on warfarin. So keep it as a second line. Okay? What else? Lactation. Encouraged in any kind of cardiac disease. If she can tolerate it. Of course, if she can tolerate it. But it's not contraindicated, of course. Most of the medications that cardiac patients take are safe during pregnancy. Most of them. Now the last one. Arrhythmias and palpitation, and it's the easiest one. So you can go through the numbers, the prevalence of arrhythmias and which one the most common, but I'm going to tell you which one is the most common. The most common one is ectopic feeds, and those are not pathological, right? So as a pathological arrhythmia, the most common one is going to be supraventricular tachycardia. And we diagnose supraventricular tachycardia when it is recurrent or persistent. Okay, so usually when it's only like short-term one or coming different episodes, or it happens only once and it was detected by her watch, because it can be detected by some kind of watches now. Okay, this is usually not the one we are talking about here. We are talking about someone who is diagnosed by the ECG having supraventricular tachycardia. This can happen when the patient is awake and conscious, and this patient can come to you collapsed. Okay, so not all of them are going to present in a collapsed state. We have diagnosed this, okay, we were okay, the ECG got it, and you know, Wolff-Parkinson-White syndrome, which is one of the commonest accessory pathways between atria and ventricles. Okay, where we see the delta wave, this one, this. Okay, this is one of the most common pictures of supraventricular tachycardia. What the woman is going to have, she's going to have palpitation, right? Racing of her heart. Um, she lost conscious for 1 or 2 minutes. And when we put the ECG, sorry, we find supraventricular tachycardia. It has some manifestations, by the way. I don't want to bother you with the ECG, but just to remember, they are having a white URS, and they are having um, very small P waves, sometimes no P waves, absence of P waves, with white QRS and tachycardia more than 120, sustained. So in those cases, how we are going to deal with them? The first line of treatment, Valsalva maneuver. This is the first line of treatment. You are going to teach her to control her heartbeat with Valsalva maneuver. If it failed to control her heart rate, then we can give intravenous adenosine. This is a really cool question. First line of treatment, and if it failed, what should we give her? As like any other cardiac condition, and as most of arrhythmias, you can control her by beta blockers. And we use beta blockers as prophylaxis for those patients, especially cases of paroxysmal supraventricular tachycardia. Okay, don't bother yourself with how it looks like or whatever. You are not going to be the one who diagnose her. Okay, so don't bother yourself now. If you are asked about which medication I can give her as a prophylaxis, beta blocker. Which medication I can give her if Valsalva maneuver failed, intravenous adenosine. If the patient came to me, collapsed, what can I give her? I can give her DC shock? Yes, sure. Can I give her verapamil? Yes. Can I give her beta blocker? Yes. But usually, in cases of collapse, and if the monitor came with uh, pulseless supraventricular tachycardia, we are going to give DC shock. Okay, so when you feel the pulse, there is no pulse, but the monitor show supraventricular tachycardia. This is when we are going to do a DC shock, or direct current cardioversion. Second one is AS. And I mean atrial fibrillation or flutter. Both of them need anticoagulation, as we mentioned before. You are going to treat a case of acute episode, usually by DC shock, especially if she is collapsed. But if she is not collapsed, she is awake with AF, and it happened, by the way, we are going to give her flecainide or botulinum. Remember the names because those are exam questions. Okay, guys? Prophylaxis. Again, beta blockers. VT. Now we have VT, ventricular tachycardia, not supraventricular. VT is emergency. And usually she's going to come to you as a case of collapse. So, DC shock. Okay, if she is now hemodynamically stable, or if she is having ventricular tachycardia, but she is hemodynamically stable, you can give her sotalol, again a beta blocker, and flecainide. Okay, prophylaxis. Guess what? Again, beta blockers and amiodarone. Those ladies, if they are having a sustained condition, they are going to be offered a cardioverter defibrillator. So this device is going to work once she is having a collapse. The device is going to work. Yes, yes, shortly. I'm going to have a break in 2 minutes. Okay, bradyarrhythmias usually are need monitoring. Okay, only pregnancy is well tolerated. If they are having symptoms, you are going to give her anticoagulation and so on. But they are not like the tachyarrhythmias. They are not like the VT or SVT or AF, of course. We have something called long QT syndrome. The most important thing about it is that it has a genetic probability, so it can be inherited. Um, those are the most common mutations associated with. I am not going to ask you to remember them. Those patients should be on beta blockers throughout pregnancy and after pregnancy. Okay? This condition is associated with sudden infant death. And as I told you, if you are having a mother with long QT syndrome, this syndrome can lead to ventricular arrhythmia. Okay? So she should have echo, of course, for the baby during pregnancy, and the neonatal team should know about it to examine the baby before discharge. Even you should refer her to genetics for her baby to make sure that he does not get the condition. Why? Because long QT syndrome, if it turned into ventricular arrhythmia, it can lead to sudden death. Okay, those are the anti-arrhythmic drugs that can be used during pregnancy. Again, this is the exam question, guys. They are not going to ask about details. So just remember which drug can cause neonatal hypothyroidism. This would be amiodarone, the one that we use for prophylaxis in case of ventricular arrhythmias. Okay, so take care. You should give it only for short-term use, not for long-term, because there is a risk for neonatal hypothyroidism. Which one of them is having risk for small for gestational age, for fetal growth restriction? This is a recall also. Beta blockers. Beta blockers. Which one of them is having fetal toxicity in large doses, but it's safe? Or in exact word, benefit outweigh the risk? Adenosine. Okay, adenosine. So they love to ask about this table. They love it. Verapamil is totally safe. Lidocaine is usually safe. Uh, Flecainide is not well, we don't have sufficient data to suggest fetal compromise. Okay, and this is this one that we use for fetal supraventricular tachycardia. If the baby is having supraventricular tachycardia, we are going to give the mother flecainide. Digoxin is not the first line. Okay, there is a whole talk article about fetal arrhythmias. Forget about it. Just remember, flecainide and verapamil are the first line. Digoxin is the second line. Okay, for us, we use beta blockers, but there is a risk for growth restriction. Amiodarone, the risk for hypothyroidism. Okay, and also it can cause growth restriction, by the way, and prematurity, but in prolonged use. And usually we don't use it in prolonged use. Okay, I'm going to stop here.